Hello, everyone. We'll give just a couple minutes for folks as they join online. Unfortunately, I do not know the CME code, but I'll try and find it and let you guys know. Can people hear online?
Yes.
Thank you.
Dr. Kara, the CME code is 48297.
That's the CME code. For those online, it's
48.
48297.
Yes.
So I'm going to start because I think we probably have a lot of conversations at the end. I'm going to get out of the way. 48297. Today we have the pleasure of having Dr. Rishi Vadera here with us today, who's, really a big star nationally in health policy, in cardiovascular health policy specifically. He's an associate professor at Harvard Medical School. He's the associate director of the Smith Center for Outcomes Research and Evaluation, where he leads the section on health policy. He's also the associate program director for the Cardiovascular Medicine Fellowship at Beth Israel Deaconess Medical Center. Rishi, it's my pleasure to call him my friend, but he's had a storied career, and I would not go by his youthful face to think about his career. He has over nearly 200 publications in leading journals, including New England Journal of Medicine, JAMA, focusing on key elements of health policy. He has 3 current R1 grants, including an established investigator award from the American Heart Association. He finished his medical school training at Mayo at the Mayo School of Medicine, and then he completed his MPhil as a Gates Cambridge Scholar at Cambridge. Then he finished his residency and fellowship at Brigham and Women's Hospital and completed his postdoctoral fellowship at Smith Center, where he subsequently joined as a faculty member. He has done remarkable work dissecting the effects of health policy using advanced statistical methods, and really expanded how we can interpret policy in a meaningful way, especially when it's challenging to really do some of the evaluations upfront when we design these policies. So without taking much away, I would just hand it over to Rishi to introduce us to his work and all he's done so far.
Thanks so much, Rohan, for that very kind introduction. And it's been really wonderful to connect with so many friends, colleagues, collaborators, former trainees, people I look up to, and make new connections with really fantastic fellows and faculty. And as Rohan mentioned, today I'm going to be talking about how we can leverage policy to improve cardiovascular health in the US. These are my disclosures. So I just want to start by laying the groundwork here, which is I think, and I think most of you will agree, that policy is one of the most powerful tools that we have to shape the health and well-being of millions of people across the country. And I would go a step further and say that long before a patient walks into a clinic or a hospital that we see, policy has already shaped their chances of living a healthy life. And, this has been a wild last 15 years because we've really been in the midst of major health policy reforms on a national scale, which collectively have had significant implications for access to care, quality of care, and health outcomes for millions of Americans. And so today, I'm going to walk through some of the evidence on how national policy reforms, which have been enacted while we've been practicing, most of us have been practicing, I should say, across 3 different presidential administrations have impacted cardiovascular care delivery and health. And I'll also highlight some of the pressing challenges we face, particularly with the passage of the One Big Beautiful Bill most recently. But I want to start by just zooming out. Everyone has probably seen an iteration of this slide by reminding everyone that the US spends more on healthcare than any other country in the world. And the rate at which we're spending money on healthcare is increasing more steeply relative to other countries. And many people often say, well, why does that matter? Well, it matters because if healthcare accounts for a higher and higher percentage of your GDP, you effectively have less money to spend on other things like education, as an example. And so one of the common questions that folks ask is, we spend more, are we getting more bang for our buck? And the short answer is no. This is a table that was published by the Commonwealth Fund, which shows how the US healthcare system performs compared to many other higher income countries. And you can see that we rank dead last on measures of access, equity, and healthcare outcomes. This almost feels cathartic to look at right now, but this is President Obama signing the Affordable Care Act into law back in 2010. And the ACA was passed in the hopes of addressing many of these shortcomings that I just outlined in terms of lots of spending, but suboptimal outcomes. And the ACA had three major goals. The first was to improve access to healthcare. The second was to improve quality of care, and this third was to reduce healthcare expenditures. So I'm going to start off by focusing on how the ACA impacted access to care. This may be hard to remember, but prior to the ACA, nearly 50 million working age Americans were uninsured in the United States. And after the ACA was enacted in 2010, more than 30, now 40 states expanded Medicaid eligibility requirements, sort of liberalizing those requirements so more low-income people qualified for Medicaid coverage, which again is one of our biggest public insurance payers. As a result of this policy change, Medicaid expansion under the ACA, 20 million people gained insurance coverage, nearly half of who had cardiometabolic risk factors and disease. And you can see on the map here in blue states that expanded Medicaid, and in the orange states that elected to not expand Medicaid. And these gains in insurance coverage, 20 million people, were most pronounced amongst racial and ethnic minority groups who previously had very high uninsured rates. You can see here in the figure that the largest reductions in uninsured rates occurred amongst Black and Hispanic adults, and that those changes were most pronounced in states that elected to expand Medicaid under the Affordable Care Act. Medicaid expansion has also had a significant impact on the patients we care for in the hospital. For example, uninsured myocardial infarction hospitalizations declined far more substantially in states that expanded Medicaid, shown in the blue, from about 18 to 8%, compared to states that did not expand Medicaid, which is shown in the orange. Intuitively, the primary role of insurance coverage is to provide people with financial protection from catastrophic events like heart attacks and strokes. And so it's probably not unsurprising, sorry for the double negative, that Medicaid expansion has led to substantial reductions in catastrophic expenditures and out-of-pocket spending, which is shown in the yellow line. And then on the outpatient side, there's a large body of evidence, and there's thousands of studies on Medicaid expansion now, but there's a large body of really rigorous quasi-experimental work that has shown that expansion increased access to primary and specialist care. It increased the identification and treatment of cardiometabolic risk factors. And these incremental gains in insurance coverage that have been associated with increases in primary and preventative care have really paid off. And that's because there have been a series of economic evaluations that have shown that death rates amongst working age adults declined in expansion states compared to states that did not expand Medicaid, and that this has largely been driven by a reduction in cardiovascular deaths. One recent study that just came out this year estimated that Medicaid expansion has saved approximately 30,000 lives since its enactment in 2014 through 2022. And it's just worth highlighting as a reminder that 10 states shown in orange have still not expanded Medicaid, which have left nearly 2 million working age adults uninsured. We call this the coverage gap. This is a work that was led by Andrew Oseran, who was a T32 fellow with me and now is a faculty member and with our group, showing massive gaps in cardiovascular risk factor screening and treatment amongst uninsured adults in non-expansion states. I don't usually talk about Medicaid expansion anymore, but I put this back in because it's very pertinent to what I'm going to talk about at the end, which is the One Big Beautiful Bill and some of the gains that may be undermined by the passage of that bill. So I've shown you evidence that the ACA's Medicaid expansion meaningfully improved cardiovascular care and health in the US. Now I want to move on to the other major policy goals of the ACA to move us towards healthcare systems that provide higher quality or higher value care at lower costs. And the way the ACA aimed to achieve that was by shifting us from a healthcare system that prioritizes volume to a value-based payment system that ties reimbursement to quality. And if you think about it, under the traditional reimbursement paradigm that we all have been exposed to, we're incentivized to do more. Our professionalism prevents us from doing that, but do more, see more patients, do more procedures. And there has never really been a mechanism to hold people accountable for quality and value. And that's the biggest critique of the fee-for-service architecture. It's that there's a financial incentive to do more stuff that may not necessarily improve care or outcomes. And so the ACA moved us away from this approach through the implementation of value-based pay-for-performance programs shown in the middle here, like the value-based purchasing program and the hospital readmissions reduction program, which began tying reimbursement to quality measures and outcomes. And then it also started pushing us towards the right towards alternative payment models, which Erica and Nihar have done a lot of great work on, really trying to focus on a more population streamlined based approach to payment. And I'm gonna just spend a couple of minutes talking about these programs in the middle. First, because they're massive programs that were rolled out in a mandatory fashion across 3,000 hospitals, with more billions of dollars in penalties at stake. And also because we have robust or inconclusive evidence, I would say, on their effects. And the first program that's worth highlighting is this program called the Value-Based Purchasing Program. This was established in 2011, and the goal of this program was simple. Medicare basically said, let's provide a financial incentive to improve care. And to do so, the VBP, as it's called, began giving hospitals across the country performance scores based on several measures, including 30-day mortality rates for myocardial infarction, heart failure, and pneumonia. And hospitals that achieved high performance scores received a financial reward, while those that received low scores are financially penalized. This is a budget neutral program, $2 billion at stake every year. So a key question that some have asked is, has the VBP improved patient outcomes? And the short answer is no. This is a quasi-experimental study that was led by Jose Figueroa's group at the School of Public Health, BMJ, and it shows that US hospitals participating in the VBP, shown with the red line, experienced no change in 30-day mortality rates for MI, heart failure, and pneumonia compared with hospitals that did not participate in the program, shown with the blue line. If anything, the program seemed to slow declines in mortality at participating hospitals. What about patient care experience? Another major focus of the program. We care about patients' perspectives on what their experience in a hospital is like, and that captures an important dimension of quality that more traditional measures maybe don't capture. And as you can see in this figure, VBP hospitals experienced no significant change in patient care experience compared to hospitals that did not participate in the program. The second major program that was rolled out into the ACA was the Hospital Readmissions Reduction Program, which probably, I think, elicits some PTSD for Rohan and I. In the early 2000s, nearly 1 in 5 Medicare patients were readmitted to hospitals within 30 days of discharge. Big problem, cost the government billions of dollars a year. And under the ACA, the HRP was enacted, and it began financially penalizing with hospitals with higher than expected 30-day readmission rates for pneumonia, heart failure, and pneumonia. And the goal of this program is very simple. Let's provide an incentive for hospitals to improve discharge planning, care transitions, post-discharge care, all to reduce the likelihood that a patient needs to come back to the hospital. Makes total sense and a worthwhile venture. And early evidence suggested that this program was a success. This is a paper that was published by Zuckerman et al. In the New England Journal, which showed that readmissions declined significantly amongst conditions targeted by the program, MI, heart failure, pneumonia, relative to conditions not targeted by the program. Reduction of about 3%, they estimated. 3% may seem small. It's actually quite big when hospitalizations are expensive, billions and billions of dollars a year from the federal government's perspective. And around this time, I was actually a resident. I was telling the story that earlier today, and I was working in the ED, and I had rotated in the ED before as a medicine resident at the Brigham, and then I was rotating there again, and something had changed. Someone was coming around and basically telling us, hey, you shouldn't readmit this patient or you shouldn't admit this patient because they were admitted less than 30 days ago, put them in OBS. Maybe try to treat them in an ED and send them home, which felt very weird. And so we did this study in the BMJ showing that although readmissions declined, the rate at which patients were coming back to the hospital within 30 days of an admission and being treated in an ER or an observation status had gone up. So this could be good if we're using inpatient care appropriately, or it may reflect a shift in triage patterns in response to the policy. And so this raised some concern that maybe an incentive to reduce this incentive to keep people out of the hospital or shift the way we triage patients may have adverse consequences for patients at the margin who might have benefited from higher level care. And so Rohan and Harlan led this really rigorous and fantastic study, basically showing that there was no significant increase in heart failure mortality, which is one of the conditions that folks had been really concerned about after the HRP was announced. Then we had a study come up, published a few months later, that showed that there was a significant increase in heart failure mortality, and it seemed to be concentrated in people who weren't readmitted after discharge, excluding hospice patients, maybe lending some mechanistic insights into the concern. And then a bunch of other studies came out in this period, 5 other studies, all showing mixed findings. Some saying there was an increase in mortality, some saying there wasn't. And the evidence is really mixed on this issue. And I think one of the key takeaways, actually, I think one of the part of we became friends over this is we sort of agreed that our experience and uncertainty about the effects of policies like the HRP, even to date, have highlighted the importance of moving away from an aspirational approach to policy and towards a more empirical one. And perhaps we need to start generating more rigorous evidence on the effects of policies before widespread implementation, whether that be through randomized trials, step wedge trial designs, or quasi-experimental approaches. And this is something Deepak Bhatt and I wrote about back in the day, and then Kian McCarthy and Muthu Vaduganathan also wrote about, and then I think Rohan wrote about in the BMJ. And so, if we think about it, health policies, we can make therapeutic advancements, basic science advancements, but health policies have the potential to impact the care of innumerable patients and probably need to be held to the highest evidence-based standards. And doing so would provide some clarity on what works and what we should expand and double down on and what doesn't work and should be sunset. The other reason I think it's important to try to get policy implementation right the first time and prioritize rigorous evaluation before widespread implementation is because the financial stakes can be quite high. This is an example of the penalties that have been posed by value-based policies, and this is just a select example. There are many other policies that I'll provide a quick overview of. The VBP, the HRP, and the Hospital Acquired Condition Reduction Program, which focuses on financial incentives to reduce things like catheter-associated urinary tract infections. And the penalties imposed by these programs, it's an interesting conundrum, have really disproportionately impacted safety net and minority-serving hospitals that tend to operate on they have lower operating margins. So these are institutions that can't really absorb the hit well, and this hospitals like the Boston Medical Centers in Boston, the Bellevues of New York City, the Cook Counties, many hospitals that many of us have worked at that tend to care for socially vulnerable populations. And this was an analysis led by Rahul Agarwal when he was a BI resident, just showing that these were the sites that were really enduring or absorbing these penalties more heavily. And it's raised a really interesting philosophical debate that reasonable people fall on either sides of. And it's right now when we compare hospital performance or how practices are performing, historically, many of these programs haven't accounted for differences in the social risk of populations, whether it be poverty, neighborhood disadvantage, housing instability, all of which I think we agree are tied to health. So on one hand, it doesn't make sense to risk adjust for those types of social risk factors because doing so normalizes holding safety net and minority serving hospitals to a lower standard of care. And risk adjustment is sort of entrenching or accepting inequities in care. On the other hand, by not accounting for social risk factors, we may be punishing hospitals that are simply caring for a low income and sicker patient populations. And maybe that's not the carrot and stick approach isn't the ideal way to do that. And we've talked about this challenging tension in this piece that was led by Suhas Gandhi when he was a Harvard medical student, highlighting the possibility that value-based policies have been unintentionally regressive. And so under the Biden administration, CMS began placing equity front and center of their value-based policies, enacting changes to grapple with the fact that it probably doesn't make sense to heavily penalize hospitals or practices that care for lower income patients. But it also doesn't make sense to hold them to a lower standard of care. And Doug Jacobs, who's the chief transformational officer at CMS, has really spearheaded a lot of that work. And the way I think it's sort of been a clever work around acknowledging both sides of this argument. The way CMS has tried to really advance equity as part of these programs now is by enacting some key changes. And one example is the value-based purchasing program, which is the first program that I talked about, will include a health equity adjustment beginning in fiscal year 2026. Now, this was one administration. Things may change under this current administration, but the goal was to sort of give hospitals that were providing higher quality care and taking care of a higher percentage of low-income patients a bonus in their performance scores, acknowledging the fact that perhaps their patient populations are at higher risk for poor outcomes. And in this economic simulation study, we found that actually the consequences of just this subtle policy shift were big, resulting in about an increase of $45 million in payments a year to safety net and minority serving hospitals. And this was an analysis led by Michael Liu when he was an HMS student working with me. So that's pay for performance programs, but it's worth talking about alternative payment models because I think this is the direction the country is going in. I think these are the type of payment models that we are increasingly for the fellows, but also for the faculty going to be exposed to and are going to need to understand how to function well in. And I want to talk about accountable care organizations. So ACOs, for those of you who maybe aren't familiar, are when a group of providers come together and basically take responsibility for total costs of care and outcomes for a population of patients over a period of time. And what happens is Medicare basically says, and commercial payers are doing this too now, here's the benchmark for spending. Here's how much we think you should be spending on this population of patients over the course of a year based on their risk profiles. If ACOs or the group of providers that have come together spend less than that amount, they share in the savings. So they sort of get a bonus. And if they spend more than that benchmark on a patient population, in some versions of the ACO, nothing happens. In other versions, they effectively get penalized. This is a form of true population-based payment. Now we're talking about populations of patients and managing quality and spending all at once. And this is just a figure that shows how many people have enrolled in ACOs over time. This is just the Medicare population. It's about 11 million beneficiaries are in an ACO. They usually get a letter that just says the primary care doctor is part of an ACO. So we've seen this increase over time. We've also seen an increase in ACO participation amongst commercial payers. So this population-based form of payment is coming. So what does the evidence tell us about ACOs? There have been a few analyses that have looked at this. Mike McWilliams did sort of the seminal New England Journal study on this. And more recently, Amelia Bond and Drew Kular published a paper in JAMA, which this figure shows, which basically estimated, it found that ACOs experienced reductions in spending compared with controls. And they estimated that ACOs saved the federal government or Medicare about anywhere from $4 to $8 billion over 6 years. They found that there was, Mike McWilliams has shown there's really been no changes in quality. And I think the way that's couched is quality hasn't worsened despite the reductions in spending. And Erica had a nice study recently in JAMA Cardiology highlighting that when you look at cardiovascular measures, they haven't worsened too. So, this is potentially a bright spot. We seem to be generating savings, maybe not improving quality, but it's not getting worse, right? The concern is if you're reducing spending, you're stinting on care and perhaps quality gets worse, but no evidence of that. I've shown you evidence on some of the biggest value-based programs that were rolled out under the ACA, and that ACOs have potentially been a bright spot in all of this. But it's just worth highlighting that I've just highlighted the big programs. This is just a small fraction of a large number of value-based payment models that Medicare has rolled out. This has been a period of incredible innovation and experimentation worth doing. You've probably heard about bundled payments, the merit incentive-based payment system. CMS just announced a model encouraging states to participate in global budgets, which has been the case in Maryland for a while now. And the figure on the right really just captures how many models and programs CMS has rolled out. But what's been a little disappointing, experimentation and innovation is important, but despite the proliferation of these models, this is a piece that CMMI published. Brad Smith, who was on DOGE actually, but when he ran CMMI, published basically saying during the past decade, the center has launched 54 models that address critical areas of healthcare. However, the vast majority of the center's models have not saved money. The exception, I think, being ACOs. And then this Congressional Budget Office, back when the ACA was rolled out, they projected that a lot of these value-based payment models would result in about $3 billion in reductions in spending. And then the more recent estimates that have come out from the CBO have demonstrated that actually most of these value-based models have actually increased spending, paradoxically, by about $5 billion over a 10-year period. And that doesn't account for, all the infrastructure building that health systems are doing. I don't know about you, but, when I was at Brigham, like spending hundreds of millions of dollars on consulting to figure out how to do well in these programs. So, but the bright spot in all of this doesn't include ACOs. So I said ACOs have saved about $48 billion. So perhaps we've come out even in this decade of payment reform. I want to talk about another insidious trend that's occurred during the value-based era, which actually all of us in this room can relate to, which has been the acceleration of consolidation and corporatization. It's an insidious consequence of the value-based era. I'll talk about why in a second, but on the left, you can see that hospital mergers have really increased sharply since 2010. And that's when the ACA was rolled out. And on the right, you can see that we've gone from a country of thriving small business medical practices, effectively independent practices, where only 40% of physicians in the country were employed by a health system or corporate entities in 2014, to that nearly doubling to 80% by 2024. That's a huge shift in how our healthcare landscape is structured. It's kind of a startling trend. And I think it's been the consequence of intentional policy levers that have been pulled. And what are those policy levers? Well, if you talk to folks, I spent a lot of time actually now talking to folks in private practice for a variety of reasons. The administrative and regulatory burden in the value-based era has been immense. If you talk to a solo practitioner in Florida, they will say, I don't know how to deal with MIPS. The rules are changing every year. I don't know how to report measures. I just want to practice medicine, right? And so this has created a little bit of a fertile ground for clinicians to sort of give up their practices. We've also seen a decline in physician reimbursement. Actually, when you adjust for inflation, hospital reimbursement has gone up over time. Physician reimbursement has gone down. So perhaps a little easier to manage that in a big health system, harder if you're an independent practice of 3 people. And then at the same time, I think another big policy lever has been the lack of site-neutral payments. Right now, if you see a patient as part of Yale or the BI or Brigham or whatever it may be, and you're part of the health system and you provide the exact same service to them, the health system is reimbursed way more than than an independent practice that provides that service. And there are lots of reasonable arguments for that, but right now we live in an era where there aren't state neutral payments. And these are the three things that I think have driven these broader trends. Why are practices in small hospitals willing sort of to give up their independence now to larger health systems? This is part of the reason why. And I think all of the health systems we work for have been impacted by these national changes in the healthcare landscape. BI, the institution I work for, has aggressively tried to acquire or merge with other sites, most recently Lahey Hospital. This is actually one of my trainees. It was front page of the Boston Globe. Devalued, disempowered, and unseen. Mass General Brigham doctors react to latest merger step. And then on the right, it was Yale merged with St. Raphael, I believe, many years ago. And then there had been discussions about acquiring 3 more hospitals. So we've seen consolidation as health systems get bigger. It's inevitable that they become a little more corporatized, and perhaps that intimacy that we as clinicians appreciated about health system sort of erodes as a result. There are some pros to mergers and acquisitions, but there are some downsides as well. So why is this important? I talked about how consolidation and the changes in the way physicians are employed have been an insidious consequence of the value-based era. And why does that matter? Well, it's because there's an abundance of evidence that has shown that healthcare consolidation increases prices and does not, for the most part, on average, improve quality. When health systems, the CEO of health systems are trying to get these mergers approved, one of the concerns that state regulatory agencies always bring up is that, well, you're merging so that you have more power at the negotiating table with insurers and you can extract higher prices from them. Health systems and smart CEOs will often say, no, we're trying to scale. We're trying to become more efficient. We're trying to increase access. But on average, the evidence suggests there isn't really a net benefit in terms of quality, but the price of a cardiac catheterization. By price, I mean how much an insurance company has to pay to the health system or to the provider goes up after health systems consolidate. And the reason I want to bring this up is so much of the value-based era has focused on utilization. There's low-value care. There is low-value care in this country, and it's probably quite pervasive. Most of the empirical work suggests that it's pervasive. We focused a lot on the quantity side of things. We haven't at all, from a regulatory standpoint, focused on the prices. Medicare and Medicaid set prices for services and procedures. The commercial market is a free-for-all, right? The commercial market prices are driven by competition, how much market power you have. And we haven't addressed the price problem. And Uwe Reinhardt, the late Uwe Reinhardt, was sort of a legendary health economist who once said, it's the price is stupid. And so this was a piece written in Health Affairs to commemorate him and sort of looking at all the evidence to date, saying it's still the price is stupid, why the US spends so much on healthcare, and a tribute to Uwe Reinhardt. So again, I just want to emphasize that if we posit that there's something about the value-based era that has accelerated consolidation, then we have paradoxically worsened the price problem. And we have no regulatory infrastructure in place to control that while trying to address the quantity problem. The other thing I'll say is because of the policy levers I just mentioned, in terms of making this sort of I don't want to say unfriendly, but a less friendly environment for small independent practices to thrive, private equity has really seen an opportunity, has seized the opportunity to enter healthcare. And it's in part because smaller hospitals and smaller practices are now much more willing to sell and give up their sites. And this was an analysis led by Vicki Bartlett, who's a resident at the Brigham, basically showing that since 2020, private equity acquisitions of clinics and practices have surged. So private equity has, all of a sudden, someone was sitting in a room and said, wow, cardiovascular disease is common and they do a lot of procedures and they're highly reimbursed. Let's start acquiring practices. And so that's what they've started doing. So this is changing the cardiovascular care landscape as well. And private equity firms are smart. They're not acquiring practices randomly. You can see that their acquisitions are highly concentrated in specific areas. usually in states with less, from a regulatory standpoint, less regulatory red tape, but also in areas that allow them to gain market power to negotiate higher prices and higher reimbursement from payers. So this is a strategic, and there's a lot of work that's been done by Zuri Song, Yashaswini Singh, basically showing that when private equity takes over a practice, we don't have this evidence in cardiology, but dermatology, ophthalmology, GI, specialties where private equity has had a presence for a long time, very clear evidence that there are three things that happen once private equity acquires a practice. Charges go up, prices go up, and MDs tend to get, there's MD turnover and are often replaced by advanced practice practitioners. So what happens when private equity takes over a hospital? This was an analysis published in JAMA by Zuri's group showing that hospital-acquired adverse events increased by about 25% after private equity acquisition compared to control hospitals that aren't acquired by private equity, despite private equity firms admitting a lower risk pool of patients. And there's lots of interesting anecdotal stories about how they do that. And then this was a paper also published in JAMA by Anjali Bhatla, who's a Hopkins Cards Fellow and works with our group, basically showing, you can see sort of this nice parallel trend between control hospitals shown in the red and private equity hospitals that were eventually acquired by private equity in the green, and global measures of patient care experience are similar at these sites, and then they start to diverge after acquisition. So you see about a 5 percentage point decrease in global measures of patient care experience after private equity firms acquire hospitals. And just for context, that exceeds changes in patient care experience that we witnessed during the pandemic, in a period where we saw an incredible amount of health system strain. We've been doing some work focused on how this impacts cardiovascular care. This is a paper that Daniel Johnson, a Sarnoff Fellow, published with our group in JACC recently, basically showing that, hey, it does look like, however they do it, we don't know, or we have some sense of it, but private equity firms seem to admit a lower risk pool of heart failure patients. Despite admitting a lower risk patient population with heart failure, 30-day mortality and 30-day revisits don't change. Perhaps that's a good thing. Outcomes aren't getting worse, but rates of right heart catheterization and coronary angiograms go up. This private equity issue, I've talked about value-based era, mergers and acquisitions, how we've created fertile ground for these external stakeholders to come in and invest in healthcare, has really captured the national spotlight. In Massachusetts, we just saw the implosion of the Steward healthcare system, and it had direct actually consequences for us, because all of a sudden we were getting 10 transfers a night, because the hospital, one of the hospitals, St. E's, was struggling and didn't have the resources, the infrastructure, the MDs to take care of patients. And so all the other health systems were absorbing that volume. And so a lot of patients were experiencing delays in access to care as a result. Ralph De La Torre, who was the CEO of Steward at the time, was actually a former BI cardiac surgeon, was held in contempt of Congress because he didn't show up to the Senate hearing about what happened to Steward under his stewardship, no pun intended. And then I think, in here, we've seen that too with Prospect, right? There were discussions about, and Nihar probably knows much more about this than me, about Yale merging or acquiring some of the Prospect hospitals, 3 of them. And then, that's sort of been at a standstill, in part because of the books and how things look at those sites since private equity has invested in them. And the Senate Budget Committee basically released a report. And it was a bipartisan report that we contributed to, basically calling out this issue and saying, this is a major problem. We need greater regulation. So that's the value-based era. Mergers, increased prices, the entry of external stakeholders into our healthcare landscape. I want to switch to the Biden administration, another cathartic photo potentially, where Joe Biden is signing the Inflation Reduction Act into law. This was another major health policy reform. We've seen a lot of them, the first since the Affordable Care Act, that aim to take one of the biggest problems that our country has faced for a while, take the bull by the horns and address it. And that was the high and rising costs of prescription drugs. This is a figure published by the Kaiser Foundation that showed that nearly 1 in 4 Americans has difficulty affording prescription drugs. And the Inflation Reduction Act, it did a lot of things, but it had some powerful prescription drug provisions in it. The first provision, which has gone into effect as of last year, or this year, I should say, is that it caps out-of-pocket spending on prescription drugs for people in Medicare at $2,000 a year. Historically, people in Medicare would enter this donut hole if they spent a couple $1,000s where they had no coverage, and then they would absorb this catastrophic hit for high-cost prescription drugs. It also expanded low-income subsidies in Medicare, effectively making co-payments and the premiums very, very low cost for low-income Americans. And then there were other provisions like capping insulin costs. I don't know if you guys remember this era, but there was an era where people were on the streets holding signs saying, "I can't afford my insulin." And so that was a priority in this bill, was to make sure insulin, which has been around for a long time, that the cost of insulin, out-of-pocket costs, were capped, and among other things. And this was just enacted this year, but we published this paper in JACC, led by Prihatha, a BI Cards fellow, basically estimating what the impact of the $2,000 spending cap will be. And in effect, 1 million people with cardiometabolic risk factors or disease will benefit from this out-of-pocket spending cap. 1.3 million additional people will benefit from the expansion of low-income subsidies. And her estimates suggest that the median out-of-pocket savings would be about $900 per year, and that the cumulative effect of this provision for people with cardiovascular risk factors and disease would be an out-of-pocket savings of nearly $2 billion per year. So not insubstantial, and particularly meaningful for people whose out-of-pocket prescription drug costs are $10,000, $15,000, $20,000 a year. There's a subset of the Medicare population who that happens to. What about the insulin cap that I mentioned as part of the Inflation Reduction Act? This was an analysis led by Rebecca Meyerson and JAMA that basically looked at people in Medicare and people less than 65 years of age, not in Medicare, as a control, and found that the insulin cap led to a substantial increase in insulin fills when compared to a control group. So those are two big provisions in the IRA, but the biggest one is this. For the first time in the history of the country, Medicare can actually now negotiate the price of drugs with manufacturers. Historically, it was a take it or leave it situation where Medicare just had to take whatever price the manufacturer said they thought their drug should be the price of their respective drug. And a year and a half ago, 2 years ago, Medicare announced the first 10 drugs that would be part of this price negotiation. Note that 7 of those first 10 drugs target cardiometabolic risk factors and or cardiovascular disease. And what you can see here is the result of that price negotiation. So I just want to emphasize, this isn't what people pay out of pocket. This is just the list price of a drug. What people pay out of pocket is affected by copays, the structure of their plans, but reducing the list price of drugs does have an impact on the downstream out-of-pocket costs for patients. And you can see that medications like apixaban decreased by more than 50%, Jardiance by a lot, rivaroxaban by a lot of Entresto. So the list prices of many of these drugs reduced by about 50% or more, which is quite meaningful for folks with cardiometabolic risk factors and disease. We made a lot of progress. This law was just passed. We don't have empirical work, looking at the natural experiment of how it's changed things. We have the projection studies that I showed you. And so I think there are some major remaining questions. The biggest pushback, and I was part of this health policy commission where, people that were drug manufacturers, CEOs of these companies were coming in and saying, we're going to invest way less in drugs because of this, because someone has to absorb the cost savings that patients are experiencing. And the people that will absorb that are in part manufacturers, the loss from it, and then payers, so insurance companies. And so there's this concern, and I think this is a very legitimate concern, that there will be an affordability innovation trade-off. The second concern, I think, is, will costs be passed on to patients in other ways? One of the clever things about the IRA is it said that Medicare prescription drug plans can only increase their premiums by 5% a year while these provisions are going in place, because they were concerned that if insurers have to absorb the loss of reductions in prescription drug prices and out-of-pocket spending, that they would just increase premiums and generate revenue that way. And so I think that's a real concern. And actually, last year was the first year where we saw the effects of this. Across the country, Part D plans increased their premiums to the max they could for the most part. It was all over the news. But good that that protective measure is in place such that they couldn't go past that 5%, approximately 5%. And then I think the biggest question is, these are great provisions. They make sense. People should be able to afford drugs and not be bankrupted by it. But ultimately, we care about reducing financial strain and financial burden, but our hope is that this will improve adherence and outcomes. So what will the effects of this policy be on adherence to key cardiometabolic medications and clinical outcomes? This is that was Obama, Biden. I skipped one, Trump administration. We're jumping to the most current Trump administration. This is a picture of President Trump signing the One Big Beautiful Bill. There's lots of stuff in this bill. I'm just going to highlight two of the biggest things that will affect all of us in direct and indirect ways. The first is that the bill will cut about $1 trillion in funding to Medicaid, which currently insures about 70 million adults, and those cuts will be made over 10 years. It also introduces work requirements into the program. There are some states, Arkansas being the most notable, and Georgia more recently, that have experimented with work requirements, but this has never been a national thing. And so now in this program, adults 19 to 64 years who are in Medicaid must work 80 hours a month with limited exceptions. That seems actually quite reasonable, but I'll talk about why this is a little bit of a gotcha moment. And then they also have to participate in more frequent eligibility checks. So do work requirements work? This was sort of a seminal study by Ben Summers in the New England Journal, looking at the first year of experimentation with work requirements in Arkansas. This was in 2019. Their program was around for like 7 months before the court said it's illegal, effectively. What he found was that even in those several months, Medicaid coverage decreased by about 13 percentage points, and employment did not change. So the advocates for work requirements will argue that this creates an incentive for people to go out and work, but no change in employment. And then this analysis led by Eden Engel-Rebitzer, when she was a Brigham resident, now a BI fellow, we looked at this in patients with cardiovascular risk factors and disease, and also found a similar finding, a different data set: reduction in insurance coverage, no change in employment. And that's because most people who are able-bodied adults, as the government calls it, who are on Medicaid do work. The people that don't work are often disabled and have exceptions to that. And what the issue here is, it's the red tape and the administrative stuff that is very tricky to navigate that leads to loss of coverage. People aren't losing coverage because they're not working. They're losing coverage because the requirements are so complicated and they can't keep up. And so it's sort of a red tape mechanism. And I was talking to someone earlier about how one side of the political aisle will say, we're strengthening Medicaid by getting people off it who aren't willing to work. The other side needs to do a better job saying, no, you're just creating red tape to kick people who should be on Medicaid off it. This is going to be rolled out nationally and will have consequences for hospitals, because what are we going to do when there's a spike in the amount of uncompensated care that we need to provide as health systems? And how are we going to deal with that financially? And then I'll just highlight that Georgia just did this. Now in 2024, they expanded Medicaid. So I talked about all the evidence showing that expanding Medicaid increases coverage and improves all these things. They expanded Medicaid, but incorporated work requirements in their program. And when you compare Georgia to neighboring control states that did not expand Medicaid, you find that there was no gain in insurance coverage in Georgia. And no increase in employment. So basically their expansion did nothing, in part because work requirements made it very challenging for people to enroll in the Medicaid program. So I've highlighted the consequences. What are the consequences? The CBO has projected that 11 million Americans will lose health insurance. This says if Trump's big, beautiful bill becomes law, but it has become law. And then this was a nice collaboration between Yale and Penn, where they took some of the empirical work looking at how gains in Medicaid coverage have impacted health and well-being and outcomes, and did sort of this back of the hand calculation, estimating that this bill would result in more than 42,000 deaths annually. And this was a letter they sent to Congress. The other thing that I'll just highlight briefly that the Big Beautiful Bill does is it deeply affects SNAP. SNAP is the nation's foremost anti-hunger program. It provides nutritional benefits to 42 million low-income Americans. The goal is to reduce food insecurity. Lots of evidence that food insecurity worsens cardiometabolic health, both directly and through indirect mechanisms. You're forced to make decisions about, should I put food on the table or should I pay for my medications? Should I go to my healthcare appointment and pay for transportation, or should I put food on the table? So that's the sort of, those are the challenges that people face when they are food insecure. And then there are some direct consequences of it from the psychosocial stress that's imposed by experiencing food insecurity as a household. The One Big Beautiful Bill will reduce SNAP funding by about $200 billion over the next decade. And it will also expand work requirements in this program. So initially, the program, to get SNAP benefits, you had to work 80 hours per month if you were up to the age of 55. Now they're expanding it to up to 64-year-olds. And we recently published this paper in JAMA, basically leveraging an interesting natural experiment that emerged during the pandemic. During the pandemic, because so many people became unemployed, food insecurity spiked, and the government basically doubled SNAP benefits for low-income families. Then they de-implemented that doubling of benefits in a time-staggered way across different states as the pandemic sort of wound down. And what you see here in this natural experiment is that when you compare SNAP participants to this control group, you see a 50% rise in food insecurity after SNAP benefits were just rolled back to what they were previously. This is a program that mitigates food insecurity. It does not completely address it. And then at the same time, there's been a lot of question about what are the health consequences of this. We found significant increases in poor self-reported health and poor mental health outcomes in people that were exposed to the reduction in benefits compared to people that won't. And this is because households that experience food insecurity have to make very difficult choices. So when you take a step back, we have made intentional policy choices that have resulted in worsening income inequality in the US, more so than many other higher income countries. And now we're making intentional policy decisions to dismantle safety net programs that protect millions of low-income families that they rely on for both day-to-day living and to preserve their health. And it's interesting because we're living in this era of extraordinary scientific breakthroughs, yet the promise of better population and cardiovascular health may get derailed by what I think has been sort of short-sighted policy. So I'll just end by saying that we talked about the Affordable Care Act. Medicaid expansion, all the empirical work is pretty unanimous. This was a really good thing. Increase access to care, increase preventative care, reduce deaths. Value-based policies, another big tenet of the ACA, mixed evidence, some bright spots. There's been potentially this paradoxical increase in costs that the CBO highlighted. And amidst all of this, we're starting to talk about it more, but we're seeing intensifying consolidation and corporatization of health system. It's still the price is stupid. As Uwe Reinhardt would say, we are not doing anything about the price problem in the US. And to some degree, it's because health systems rely on higher reimbursement from commercial payers to offset the fact that Medicare payments are not as high and Medicaid payments are not as high. The second major policy we talked about was the Inflation Reduction Act under the Biden administration. Really important prescription drug provisions. I think the remaining questions are, will there be an affordability innovation trade-off? Will patients bear the costs in other creative ways? So policy is often a game of whack-a-mole. And how will this affect adherence and clinical outcomes over the long term? And then we talked about the One Big Beautiful Bill and how this program will levy big cuts to safety net programs, Medicaid and SNAP. And it's hard for me to be even circumspect about this. I think this will negatively impact the health of millions of low-income Americans, if not reversed by future administrations. So thank you very much. And I just wanted to highlight that this work was led by a bunch of really talented postdoc fellows and trainees in my group. Wanted to thank Harlan, Rohan, Eric, Nihar, Kamal, Erica, and lots of new friends for the invitation.
Well, first of all, thank you for a tremendous lecture educationally. I learned so much, and I really appreciate your visit, especially on this time of year. And so pertinent with what's going on in the world. But you kind of touched on this, and my question may be, it's hard for me to even state it effectively, but let me give it a try. One thing that you shared was this whipsaw kind of impact of different policies, and the fact that some are enacted with a lot of good plans, but with very little evidence.
Mhm.
And it made me thinking that in the device space, for example, to use an example, we might approve a new device, but require some
Post-market
mechanism
surveillance,
of follow-up to assure safety, quality, and impact before Medicare will, and so you have required reporting. I'm curious methodologically in this policy space, if the CBO or other drivers of payments have in fact thought about implementing a similar strategy of ensuring systematic reporting and embedding that data collection in a systematic way to how policies are monitored over time, so that there's a mechanism to peel back policies that that aren't working based on approved performance indicators.
Yeah, it's a really great point. And what I would say is, I actually think CMS, and this is probably a function of the work that Yale Core has done with them, has really intensified their efforts actually to move towards randomized evaluation. So the most, Nihar, I feel like you know this, the most recent version of bundled payments is a mandatory randomized model. So they've rolled it out in randomized geographic ways in a mandatory fashion. And that allows for strong empirical evaluation before you do it nationally. There are natural experiments that emerge that you can leverage. But I think the challenge is, if a program is just rolled out nationally, you end up in the situation which we were in, which is like we don't know. Like, we don't know the truth because there's no control group, there's no counterfactual. And so it's tough to do before and after analyses without what we call an identification, a control group, basically, a counterfactual. And so I think maybe more, and CMS has certainly done this in the last few years, being more thoughtful about the rollout can often enable rigorous evaluation after a policy has been rolled out, whether it be time staggered or just randomized. Eric, you had a second point.
I'll
Okay.
defer to others.
Yeah.
Questions come out.
Thank you. Thank you for that incredible talk. That was really an awesome overview. And I know we talked a little bit about this earlier today, but I was wondering if you could speak a little bit more just kind of on this idea of messaging, right? The fact that it seems like well-meaning groups, entities, institutions, organizations have really kind of fumbled over and over again with messaging. And so like the example you gave of the work requirements actually just being more of a red tape requirement, ironically being passed by the party that hails itself as like anti-regulation and like small government. But in fact, it's just like lots of regulation, just in a way that will, in a targeted way, decrease access for people who have the least access already. So how do you think, I think at this time, a lot of physicians, trainees, students, other healthcare providers feel pretty disheartened given how things are going.
Yeah.
And, how can we sort of individually and collectively, this is a huge question. I don't expect us to fix it today, but what are some of your thoughts about how, whether it's via individual or collective advocacy or messaging, how do we begin to reverse some of these trends, which are really, I think, as if you've painted quite clearly, not going in the right direction?
Yeah, I mean, it's such a great point. I think I often think about the evidence generation part of things. Like we have the privilege of being in these incredible institutions where there's abundant resources and infrastructure to sort of generate the evidence that ultimately informs policy. But it's not just we can publish papers; you have to translate it, right? So I spend a lot of my time now basically just talking to policymakers. And I was telling someone earlier, folks on the Senate Budget Committee about the private equity stuff. So folks on the House Judiciary Committee, because there's soft levers that can be pulled to change the way people think on both aisles, to be totally honest. Now, that doesn't mean they're going to vote one way or another when push comes to shove, because there's this broader tendency to just fall in line right now. But I think the evidence, and it may not inform policy in real time, but it becomes forever documentation of how this policy impacted X, Y, or Z. And media picks up on that. And, legislatures pick up on that too. But I agree it's not just evidence generation. It's not just the researchers trying to translate it and get that information to policymakers. To some degree, the messaging from policymakers has to be effective so that you capture the attention and convey facts to the public, because the public can really change the shape of the debate. And I'm curious to see what the downstream consequences of these Medicaid work requirements would be. I don't think they're going to be favorable. I think the moment you start taking taking things away from people, people tend to revolt. So I think I would say, I've been impressed by the Republican messaging apparatus. A bunch of us have talked about it. It's impressive. The Medicaid cuts have been couched as we're strengthening Medicaid by getting lazy people off it effectively, right? And now people are buying into this narrative that there are tens of millions of people who are lazy and sitting on their mom's couches playing video games. I don't think that's true, actually. And the Democrats have sort of fumbled the messaging on this, because they should just say this is just bureaucratic red tape to get you to remove your insurance. I don't know how to improve that.
John?
Dr. Forrest? No, I really appreciated the talk as somebody whose field it's not, right? As someone who spends their time in the cath lab and doing things. I think when I look at it, and I look at both Yale New Haven Hospital, I look at the university where a third of their revenue is generated from healthcare, despite the fact that they don't own a hospital. When I look at, salaries of presidents of hospitals or salaries of interventional cardiologists, when I look at salaries of, where our administration goes, it seems that what we have here is like, we know that we can sort of provide a little bit of a better care. We can, by spending more, right? And we know probably that cutting spending is going to hurt people, and certainly disproportionately hurts people who have less. But we also know that, like, as a country, we spend way too much money on healthcare, and we haven't, that has just continued to increase. So when you look at it, I'm curious if when you look at this, you see like this is a way that we could sort of maintain, or not decrease the quality, but decrease our expenditure for it. And what do you see as to how we do that?
Yeah, so that's a great series of questions. First, I think, to answer your final point, I think population-based payment, I think ACOs really have been a bright spot in all of this. And population, they've shown us that when groups of providers get together and have a strong incentive to coordinate and integrate care, we can make a dent in spending without worsening quality. I think the price issue looms large. Honestly, like, it's easy to sit up here and talk about we need to regulate prices. That's not necessarily my stance, because the moment you start regulating prices, we're talking about reductions in physician salaries, nursing salaries. There are downstream consequences of that. But perhaps health systems need to learn how to be leaner and navigate in an environment where we don't have the luxury of extracting high prices from commercial payers, or perhaps not. I don't know. But I think the big thing to me is we're trying to move the needle on utilization. And I don't think that's what's driving that percentage of GDP. It is prices. I mean, I know that, right? And then I think you've raised a really interesting point about, I do feel like this tension between the C-suite and the frontline clinician has widened over time. And I think part of it is because health systems have gotten bigger and people feel less connected, oftentimes with the C-suites, their leadership. And so the salary thing, there's like two things. There's one argument is, well, the way we attract the best leaders in those positions, whether it's the CEO of a health system, is by paying them high salaries. So otherwise they could go elsewhere. But at the same time, in this era where people are feeling more burnt out, a little disempowered, a little more anonymous, that the optics of that aren't great. I don't know what the right answer to that is, but I'll just go back to, I think ACOs are probably the direction we're headed in. And at some point that healthcare spending as a percentage of GDP is going to get so high that we won't have a choice. We will be mandated to move towards state global budgets. We will be mandated to participate in ACOs.
Rebecca, behind me is the last question.
Sure. Rishi, thank you so much. I just want to say, like, Rishi's work has just been so foundational in understanding the impact of different policy changes. So thank you for being here and sharing with us your brilliance in this area. It's work like that we need to figure out what's working and what's not. My question is, pre-ACA, I had the opportunity to do work with Harlan and Betsy Bradley, Leslie Curry, looking at quality of care outcomes and looking at these positive deviants. So health systems that were doing like uber well on 30-day mortality for AMI, and Jephthah Curtis did that work with PCI, looking at, what's the like secret ingredients of these outlier institutions? How does that compare with institutions that are doing really poorly? And, a lot of what we found was what you're talking about, which is that collaborative nature, that easy communication, that easiness of like addressing quality gaps, of feeling like there's a safety culture. People could bring things up to the C-suite really easily. I remember like one CEO said, I walk around and I do my rounds on the floor and I ask how my patients are doing, how my families are feeling. And then I go into the physician's lounge and the nurse's lounge and see how they're feeling. And that tells me all I need to know about like how our operations are going. But with all of the ACA and regulatory demands, we have seen the growth of administrative worlds in hospitals and health systems who are trying to meet quality measures and such. And I wonder like what your thoughts are on this. Have we invested in the wrong places because we are needing to meet all of these metrics, bringing in, consultants, booming up our chart review and billing auditing groups, as without the other side of really investing in relationships, collaboration. Is that a place where we could cut spending?
Yeah, no, I think that's such a great point. And I think that work that you led is so important, because sometimes I feel like I have a meta view from big data on how we're doing, but really to like understand what the how people are performing well, you need to go to those health systems and talk to them. And I think your example is like speaks to the fact that sometimes culture is king. If you have a culture of collaboration and communication, and the hierarchy is sort of leveled, it makes it easier to fix things. I will say that we had a quality problem in the U.S. and I think that's gotten better, but it's not. Quality measurement is incredibly important. But what is the right number of measures? We've seen an explosion of measures with this enthusiasm for quality measurement. And that's normal, I think. It's like, oh, this seems to be working. Maybe we went too far on the end of trying to measure everything, and maybe we need to dial back. And CMS, as you guys know, has rolled out the Meaningful Measures Initiative to dial back some of the measures that maybe are less meaningful or less valid. Doug Jacobs published this piece in the New England Journal with Mina about how they wanted to move to they called it the Universal Foundation. Let's focus on 8 measures. I think it was 8 or 10 measures that we know will move the needle from a public health standpoint. One of the ones that you work on is blood pressure control, right? Let's just figure out, measure how health systems are doing from a blood pressure control perspective. The other is depression, as an example. And I do think that's right. I think there will always be outliers and bad actors. I don't think it's common. And I think perhaps Medicare will have its own mechanism for detecting who's billing 2,000-fold more than the average provider. But I think on the whole, most people want to do the right thing. Most people want to take good care of their patients. So let's reduce the burden. Let's focus on the things that matter. And let's focus on the things that we know will move the needle on public health. And I would say blood pressure, like high blood pressure is like an epidemic in this country. Let's address that. Let's address depression. And some of the other things they laid out in that piece, I thought were completely right. You sort of, but you know, what's the right number? And there's always a trade-off between burden, but also making sure that we're holding people accountable to high quality care. So I think we went from very little to a lot, and now we have to dial it back to something in between, because there have been so many studies that have come out that have shown what the financial and administrative burden of quality measurement is on hospitals. A great study from Hopkins. Larry Casalino published this study that's been published, that's been cited thousands of times, estimating that physician practices spend about $15 billion a year on reporting requirements for quality measurement. So it just gives you a sense of all these costs that we don't account for here that are being imposed on the system. So I think we need to get the number right, but I think quality measurement is incredibly important. So, you know, the work that's done here in that vein is incredibly important, but the right number is still probably some fewer than we have now, but not so little that we don't have enough like we did before.
Let's give my hand.
Thank you. Thanks, man. I straddled the HRP line up in PTSD.
Just like, I don't want to look at the slide though. I want to look away for a second.
Yeah.
Thanks again for
Yeah.
Unfortunately, I won't be.
Yeah, no worries.
Yeah.
Thanks, man. I
Safe,
appreciate it. Was fun talking to you.
Safe travels back.
Yeah,
Good to
I'll
see
tell
you.
August you say hello.
Please do.
Yeah.
And maybe we can find it. For
Yeah.
Yeah.
Okay.
Okay.
Yeah, good to see you, man. Hi.
Hi, I'm Ashley. Nice to meet you. So my day job, I work at like a startup company, but my evening weekend job, I work at BMC.
Yeah. You work at where?
BMC.
Oh, awesome. Yeah.